Okay, well, we're gradually getting into territory that's more and more familiar for me. So now we're going to talk about liver lesions, an algorithmic approach. And actually, I feel so silly about this, but I just, in fact, finished doing one thing here. So let me do this. I'm going to hide this slide here, and I'm going to unhide this slide. And this is the slide I want to start with. See, now I'm properly acknowledging Marathon Saturday, so I'm no longer acknowledging the wrong meeting. So I know where I am. Okay. By the way, this applies to all of my lectures. If for any reason you would like them, I'm happy to send you. Anyway, I think most of you know my email address, but if you want a copy of this lecture and the end of the lectures, just send me an email, or alternatively, maybe I'll put it into some central repository, and then you can either, you can have them if you want. Okay, so the objectives for today are to review some diagnostic sets that will help us with an algorithm approach to liver lesions. And for today's approach, I'm going to emphasize arterial phase hyperenhancement, which I sometimes refer to as APHE. So if I ever use the term APHE, I am talking about arterial phase hyperenhancement. And the diagnostic sets I want to review, there's 5 of them: diffuse APHE, mosaic APHE, rim APHE, rim APHE with peripheral washout, and peripheral discontinuous APHE. So for each one of these, I'll define what it is, and then we'll go over a differential diagnosis. But before we start that, I just wanted to emphasize that there's always a key question that we have to ask ourselves whenever we look at a liver lesion on CT, MRI, or ultrasound. And that key question is, does the patient have cirrhosis? And a related question is, does the patient have cirrhosis? And a related question is, does the patient have cirrhosis? So this question is fundamentally important, because here is the differential diagnosis of liver lesions. Liver lesions can be malignant, and here we have hepatocellular carcinoma, intrahepatic cholangiocarcinoma, tumors that can't make up their mind what they want to be, so-called combined HCC cholangiocarcinomas, metastases from outside the liver to inside the liver, and some miscellaneous things like lymphomas and sarcomas, which are pretty rare. So we can have malignant liver lesions. We can also have benign or dysplastic lesions, such as regenerative nodules, dysplastic nodules, hepatocellular adenomas, focal nodular hyperplasias, hemangiomas, and then we can have these liquidy things like cysts and abscesses. And this is not an entire list. There's other things that can also appear in the liver, but this is a fairly complete list of liver lesions that we might see. And then we might ask ourselves, okay, but the way I drew them, it looks like they're all equally likely. But what about in cirrhosis? Are they all equally likely in cirrhosis? And the answer is no. In cirrhosis, the most likely lesions are regenerative nodules, HCCs, cholangios. Notice they're the lesions sort of on the upper right. And then you say, okay, well, what about in patients without cirrhosis? Does it look the same? And the answer is no. In patients without cirrhosis, it's a very different set of lesions that are common. Here we have the lesions on your right. So cirrhosis or no cirrhosis is a very important discriminator between what things we think are likely or unlikely. So cirrhosis stratifies the differential diagnosis. And to illustrate that, I present this 53-year-old woman who has an observation in her liver, and this particular observation measures 22 millimeters. This lesion has diffuse APHE. Now, I know I haven't yet defined diffuse APHE, but trust me, this is diffuse APHE. And this lesion washes out to become darker than liver. And on the delayed images, you can see this faint rim of enhancement, which is sometimes known as an enhancing capsule appearance, or capsule in quotation marks. So the question is, what is this lesion? Well, if this patient has cirrhosis, there's only one thing this can be, and that's hepatocellular carcinoma, because this is the classic imaging appearance of HCC, and someone with cirrhosis is at high risk for HCC, so the classic appearance of a lesion in someone at high risk for that lesion is that lesion. What if the patient doesn't have cirrhosis? If the patient doesn't have cirrhosis, then we have to provide a differential diagnosis that includes adenoma, FNH, possibly HCC. And this particular woman did not have cirrhosis, and this particular lesion, although you may not be able to figure it out from these images alone, was a benign focal nodular hyperplasia. So had we interpreted this lesion as assuming this patient has cirrhosis, we would have told her, you have cancer, we don't even need to do a biopsy to prove it. If this patient doesn't have cirrhosis, we now give a very different differential, and in this case, we get a very different answer. Now, there's other stratifiers: sex, age, obesity, diabetes, alcohol use. Other things aren't important, and we'll touch upon some of them over the course of this next lecture, but the most important, cirrhosis or no cirrhosis. So with that as an introduction, let's now go to diagnostic set number 1, diffuse APHE. Now, what do we mean by diffuse APHE? We mean enhancement that encompasses the entire observation. The outer third, the middle third, the inner third are all enhancing. The enhancement might be homogeneous or it might be heterogeneous, but the entire thing is enhancing diffuse APHE. And here's our prototypical example: a 39-year-old woman. This woman has no cirrhosis, and she has a 6-centimeter mass in her liver. And notice that this mass is enhancing, in this particular case, homogeneously. The whole thing is enhancing. This is diffuse APHE. Now, this particular lesion, and this is the homogeneity. Now, this lesion on the portal venous phase essentially disappears. It becomes iso-attenuating to background liver, so it fades to iso-attenuation. So when something fades to iso-attenuation, we call it fading. When something washes out to become darker than liver, we call it washout. But this is not darker than liver on the portal venous phase. This is the same as liver, so we call this fade. Okay, so 39-year-old woman, no cirrhosis. What is the differential diagnosis of diffuse APHE? Well, again, we have to ask ourselves, is there cirrhosis or no cirrhosis? If there's no cirrhosis, a lesion with diffuse APHE is highly likely to be hepatocellular, focal nodular hyperplasia, hepatocellular adenoma, hypervascular regenerative nodule, if the patient has Budd-Chiari syndrome, fibrolamellar HCC. If it's not any of these things, you might consider that, and a conventional HCC, which is the kind of HCC you get in cirrhosis. It can rarely occur in patients without cirrhosis, but at least in the United States, it's pretty rare, except in elderly men, especially if they have diabetes, obesity, or alcohol intake. Now, in other parts of the world, it's more common to get HCC in the absence of cirrhosis, in which case it typically occurs in the context of chronic hepatitis B viral infection without cirrhosis. But at least in the southwest of the United States, we don't have much chronic hepatitis B unless we're talking about people that come from other parts of the world and migrate to the United States. But indigenously in the United States, we have very little chronic hepatitis B. And so, at least in San Diego, I don't usually think of HCC in someone without cirrhosis unless they're an elderly man with diabetes, obesity, or alcohol intake. Now, not everything that has diffuse APHE is hepatocellular. There are some non-hepatocellular lesions that have diffuse APHE. For example, some hemangiomas rapidly enhance and have diffuse APHE, but they are less than 15 millimeters. And some metastases diffusely hyperenhance and have diffuse APHE, but those are smaller than 3 centimeters. Now, what about in the setting of cirrhosis? In the setting of cirrhosis, diffuse APHE is still likely to be a hepatocellular lesion, but now notice the differential diagnosis changes. So now the most likely thing is a conventional HCC followed by a dysplastic nodule. Non-hepatocellular lesions are also possible. So small cholangiocarcinomas can have diffuse APHE, and combined HCC cholangiocarcinomas can have diffuse APHE, but those tend to be smaller than 20 millimeters. And finally, pseudo-lesions, such as perfusion alterations, can also have diffuse APHE. So this is the differential diagnosis for diffuse APHE, but now let's look at this particular patient. This particular patient, oh, sorry, before I do that, I would just want to make a teaching point though. So notice that large masses with diffuse APHE, whether you are cirrhotic or not cirrhotic, are likely to be hepatocellular. So the teaching point is diffuse large APHE, usually hepatocellular, and that's an important teaching point. Now let's go back to this particular patient and remind ourselves this patient has no cirrhosis. So if they have no cirrhosis, we can eliminate those from consideration. In addition, I want to point out that this thing is a true mass. It is displacing blood structures, blood vessels. So it is not a pseudo lesion, and we can eliminate pseudo lesion from consideration. Also, this particular lesion is 6 centimeters in size, which means we can eliminate that hemangioma and the metastasis, which are too small to be this large and this diffuse. And we're left with these 5 lesions in our differential diagnosis. So which is the most common? Well, conventional HCC is rare, except in elderly men with diabetes, and this is not an elderly man. Fibrolamellar HCCs are rare. This patient does not have Budd-Chiari syndrome, so we're left with focal nodular hyperplasia or hepatocellular adenoma. Either of those is possible. Which is more common? By far, focal nodular hyperplasia is more common, and so we will put that number 1 in our differential diagnosis. So the teaching point is a large mass with diffuse APHE is likely hepatocellular. If the mass is homogeneous in the arterial phase and then disappears in the portal venous and delayed phase, it is likely an FNH. Now, I don't want you to think that we can make the definite diagnosis of FNH based on these images. I'll show you how to make the definite diagnosis in a moment, but from these images alone, we should say FNH is most likely, adenoma second most likely, and I would stop there. I wouldn't mention anything else in my differential diagnosis. Now, this is just to show you that you might see a similar appearance in MRI. This is actually a 55-year-old man. What do we see? We see a lesion in the arterial phase with diffuse APHE. Notice that in the portal venous phase, this lesion disappears, it fades, can't even see it at all. And once again, we are thinking that in this particular, oh, and just to show you that it disappears, the lesion just disappears. So hepatocellular is the most likely, and this particular case, again, the most likely single etiology is FNH. Again, teaching point, large mass with diffuse APHE is likely hepatocellular. If homogeneous and disappears, think FNH. Now, if you want to establish the definite diagnosis of FNH, then you need to see a lesion that looks like this. So let me draw your attention to the arterial phase. We see a lesion with diffuse APHE. Notice that the enhancement of this lesion is homogeneous, except for where there are scars. So homogeneity, except for the scars, is a sine qua non of FNH. Notice that in the portal venous phase, this lesion disappears, it fades. Notice that in 5 minutes and 10 minutes, we now start seeing enhancement of this delayed enhancement of the central scar. And that's because the central scar of FNH is watery and spongy. So think of it as a sponge. The contrast gets into the sponge and doesn't get out because these are spongy scars. Also notice, and this becomes important later, notice that these scars are delicate and well-defined. We'll talk about that more again in just a moment. So the spongy scar shows delayed enhancement when you give an extracellular contrast agent. The scar is also very watery, and because the scar is watery, it looks bright on T2. And as I mentioned earlier, oh, sorry, one other thing is notice that FNHs look a lot like popcorn. So let's look at this lesion over here and notice how similar this lesion looks to popcorn. So whenever you see popcorn in the liver, if you want, you get a little bit hungry, but in addition, and maybe all of you are hungry, I could use some popcorn right now, but think focal nodular hyperplasia. And then again, just to emphasize that the central scar and its radiating network of fibrous septa are well-defined and delicate, and you'll see why that's important in a few cases from now. So scar is well-defined and delicate, but for now, the visualization of the scar helps to clinch the diagnosis. Okay, so this scar is very important. And what I want to show now on this slide is that we can see the scar on CT, but notice that on CT, the scar is not so obvious. And notice that the scar is more obvious on MRI. And the reason the scar is more obvious on MRI is more sensitive to gadolinium because of the amplification effect than CT is to iodine. So the teaching point, MRI is superior to CT for showing the internal architecture, including the scar and the radiating septa. And why is that of practical importance? Well, if you see something that you think is an FNH on CT, but you're not sure, then you may want to order an MRI to prove it. But if you think that the central scar and the internal architecture are seen well on your left with an MRI with extracellular agents, the scar and the internal architecture are seen even better, MRI with gadoxetate. So here you can sort of make out the scar, but notice that the scar is more obvious with the MRI with gadoxetate. So the teaching point is that MRI with gadoxetate is superior to MRI with extracellular agent for showing the internal architecture of FNH. And just to emphasize this, you've seen this before, but I just want to show you now a collage of 6 different focal nodular hyperplasias. Let your eye sort of wander over these 6 FNHs so that you can start to create a visual memory for the different architecture with central scars, radiating fibrous septa. Sometimes we see the network of fibrous septa going all the way to the outside. Sometimes it's a bit more sparse. And sometimes we almost don't even see a central scar. We just see this sort of radiating pattern, radiating network of fibrous septa without actually seeing necessarily a discrete scar. Okay, so now let's move on to a young woman on oral contraceptive pills and ask ourselves what we think is happening here. I draw your attention to the arterial phase and notice that this patient has a lesion with diffuse APHE. Is this lesion homogeneous except for a central scar and the fibrous network? And the answer is no, because if we look at the heterogeneity, it looks like this. So this lesion has heterogeneity that is not explained by a central scar. So already we don't really like this as being a focal nodular hyperplasia. If we go to the portal venous phase, do we see delayed enhancement of a central scar? No. Instead, what do we see? We see that this lesion looks a little bit darker than background liver. So this lesion actually washes out to become darker than liver. It's not fading to iso attenuation. It's washing out to become darker. Another thing we don't like about this as an FNH. And notice that it has pockets of non-enhancement on the delayed images. These are little pockets of necrosis, which again is not a feature of focal nodular hyperplasia. Okay, so what do we think this is? Well, this mass is about 7 centimeters in size. So it's not one of those things because those are too small. We are left with what? Well, FNH is the most common, but this doesn't look like an FNH. So we go to the second most common, hepatocellular adenoma. And the teaching point is that in a woman on oral contraceptive pills, a mass with diffuse APHE that does not meet the criteria for FNH, think hepatocellular adenoma as your #1 diagnostic consideration. In the back of your mind, though, remember that the differential does include fibrolamellar HCC. This is another example of a young woman. This woman is not on oral contraceptives, but this woman is obese and she has NASH. Draw your attention to the arterial phase and notice that there's a lesion here with diffuse APHE. And this lesion is heterogeneous, but the heterogeneity is not explained by a central scar. So it's not looking good for FNH. And notice that on the, okay, sorry, I was going to point out that, and notice that there's an area of washout back here, which is also not good for FNH. So this is another example of an adenoma. Now, we used to think that adenomas were most common only in patients on oral contraceptive pills. We now know that there are other risk factors. So other risk factors include obesity, NASH, and alcohol consumption. And obesity and NASH are probably the most important. So a teaching point, in young obese women with or without NASH, a mass with diffuse APHE not meeting criteria for FNH, think adenoma, even if they are not on oral contraceptive pills. Now, it turns out, my understanding is that hepatocellular adenomas are very rare in Japan, in Korea, in China. And one reason might be that there's just less obesity. I don't know that that's the only explanation, but one explanation is there's less obesity in those countries. So let's see in 20 years whether or not adenomas are more common then than they are now in China, Korea, and Japan. My prediction is that adenomas will be more common in 20 years than they are now due to the obesity epidemic that we will export from the United States to the rest of the world. Oh, time will tell. Okay, now this patient has Budd-Chiari syndrome, and there's a lesion in the liver with diffuse arterial phase hyperenhancement. And so now what are we thinking this is? Well, we think this is a hepatocellular lesion. Patient has Budd-Chiari, so we're thinking this is a hypervascular regenerative nodule. So the teaching point is that in Budd-Chiari syndrome, a hyper-enhancing mass is often benign. It's the so-called hypervascular regenerative nodule. And for whatever reason, they're often bright on T1. Now, I don't want to confuse anyone, but we don't yet understand these hypervascular regenerative nodules. And one of the reasons we don't is that Budd-Chiari syndrome is quite rare. So it's a rare disease, so it's not well studied. Some people believe that the hypervascular regenerative nodules in Budd-Chiari are actually inflammatory adenomas. So in which case, maybe in a couple of years, we can simplify this lecture and put this as part of this. But for the year 2018, we think that hypervascular regenerative nodules are not necessarily the same thing as adenomas. In a few years, we will know more about this, I hope. Now, this is a 22-year-old woman with abdominal discomfort. We see a large mass in the liver. The mass diffusely hyperenhances. Because this mass is large, it is not one of these non-hepatocellular lesions. There is the mass over there, and this mass has heterogeneity not explained by a central scar. And I want to draw your attention to the fact that this lesion has areas of necrosis. And there's one other thing I want to point out. Notice that on the delayed images, there is some enhancing scar tissue. So we see that enhancing scar tissue, but notice that that scar tissue looks smudgy and ill-defined. It's amorphous. It doesn't have that delicate, well-defined structure of the central scar of an FNH. So this is not the scar of an FNH. This is more of a laminated fibrotic appearance. So this is hepatocellular, and what do we think this is? This is a fibrolamellar HCC. So fibrolamellar HCCs have areas of fibrosis, but the areas of fibrosis are smudgy. They're not delicate and well-defined, and fibrolamellar HCCs often have pockets of necrosis. Teaching point looks like FNH, but too heterogeneous. Think fibrolamellar HCC. Here's a 73-year-old man. He's not obese, but he has diabetes. Patient has no cirrhosis. We see this very large mass in the liver. So here's the mass, and the mass is diffusely enhancing. It's too big to be one of these guys. It's got to be hepatocellular. And normally I don't think of HCC without cirrhosis, but I do if they're elderly and if they have diabetes. So this is an example of a conventional HCC. Teaching point, elderly men can get HCC even if there's no underlying liver cancer. Okay, let's now move on to these little lesions. So here we see a small little focus of hyperenhancement on MRI. Here we have a very similar appearing nodule of hyperenhancement on CT. Let's look at the MRI first. So this nodule enhances, and notice that it holds on to contrast, and notice that at every time the nodule is paralleling the enhancement of the blood pool. So here's portal vein, IVC aorta. Notice that this nodule is matching the blood pool, suggesting that this nodule actually contains large blood spaces. So just like the blood vessels are holding on to contrast at a certain rate, this thing has large bloody spaces holding on to contrast at the same rate. So what is this thing? It's a slam dunk. This is a rapidly enhancing hemangioma. It's smaller than 15 millimeters, so this is good for a rapidly enhancing hemangioma. How about on CT? Well, here we see arterial phase hyperenhancement, but notice that this lesion fades to isoattenuation. So now I know some of you are probably confused because this hemangioma holds on to contrast and this hemangioma fades. So why is this hemangioma fading? Well, the reason it's fading is that notice that blood vessels fade. So because CT is less sensitive to iodine than MRI is to gadolinium, the blood vessels themselves fade. Where are the blood vessels here? The blood vessels have faded to isoattenuation. Similarly, this hemangioma has faded to isoattenuation. If you look carefully, you can sort of see the hemangioma here before it disappears. It's still a little bit brighter than liver. But how are you going to make this diagnosis? An MRI, it's a slam dunk. On CT, it's not so easy until you notice on MRI that you see something very characteristic of these rapidly enhancing hemangiomas, and this little halo of perfusion alteration. So these rapidly enhancing hemangiomas frequently have so-called arterioportal shunting, which results in a cloud-like envelope of enhancement around the lesion in the arterial phase. So now we go to CT, and do we see that cloud-like envelope of perfusion alteration in the parenchyma surrounding? The answer is yes. That is very characteristic of hemangioma, very uncharacteristic of other lesions. So whenever I see a small lesion with this cloaking of enhancement around it, I think this is likely a hemangioma. And even on CT, if the hemangioma fades and disappears, I feel comfortable making the diagnosis of of hemangioma, assuming the patient has no cirrhosis. So this particular case is a rapidly enhancing hemangioma. Teaching point: dramatic arterial phase hyperenhancement with perfusional halo. Think rapidly enhancing hemangioma. If you do an MRI and you see the persistent enhancement that clinches the diagnosis, an MRI is superior to CT for showing the fact that it's following the blood pool. Finally, I show you this case over here, diffuse enhancement of this lesion over here. And there's nothing about this that necessarily makes you know this is a metastasis, but this is just to illustrate that small metastases can also diffusely hyperenhance. We'll talk about this in a few moments, but large metastases never, in quotation marks, never diffusely hyperenhance. Teaching point: small metastases may have diffuse APHE. Large metastases usually have heterogeneous APHE due to central ischemia. Okay, now let's turn to the 61-year-old man with cirrhosis. And so now we're looking at a patient with cirrhosis. And so we're looking now at the differential diagnosis of diffuse APHE in cirrhosis. And the differential diagnosis includes conventional HCC, dysplastic nodule, and non-hepatocellular lesions such as cholangiocarcinomas and combined tumors. But this particular lesion with diffuse APHE has something else. This particular lesion has washout. Notice that this lesion is darker than background liver here. So the lesion went from hyper to darker. This is not fade, this is washout. And in the setting of cirrhosis, the combination of APHE plus washout equals HCC. So teaching point: in cirrhotic liver, a mass greater than a centimeter with diffuse APHE plus washout, this is diagnostic of HCC. And here is a 22-year-old, 22 millimeter mass in the liver. And this mass also has diffuse APHE, but this mass has something else on the delayed images. It has an enhancing capsule. Enhancing capsule is not quite as good of a feature for HCC as washout, so we require a larger size. So the teaching point is that in the cirrhotic liver, a 2-centimeter mass with diffuse APHE and capsule is diagnostic of HCC, but if it had washout, it would only need to be a centimeter to make the diagnosis. Okay, and then finally, we have these pseudo lesions, which are so-called perfusion alterations that can also have diffuse APHE, but pseudo lesions are not true masses. So how can we tell? Well, first of all, let me point out the lesion over here. The lesion is here, and notice first of all that this lesion is somewhat wedge-shaped. Notice that this lesion doesn't look round. And also notice that within this lesion, there's a blood vessel that goes undistorted into it. No self-respecting mass would allow a blood vessel to just go right through it undisturbed. So the fact that this blood vessel is undistorted, undisturbed, tells us that this is not a mass. This is just an area where the blood flow to the liver is altered, a so-called perfusion alteration. So teaching point, diffuse aphe with no mass effect. In other words, undistorted vessels, think perfusion alteration. And this is not my fault. I'm the messenger. I did not invent this. But these perfusion alterations have different acronyms. So they can be called transient hepatic enhancement differences, or THEDs, transient hepatic intensity differences, which is for MRI, transient hepatic attenuation differences for CT. So this is a THAD, this is a THID, and this is a THED. And this one applies to CT or MRI. This one applies to MRI, and this one applies to CT. Don't blame me, not my fault. I did not invent that terminology, but just want to review it for you. Okay, now, I want to reassure you that that is by far the longest diagnostics that we do. And I should have warned you in advance. So I don't want anyone to be thinking, we have to go through 5 sets that are that long and do 5 of them. No, the next 4 are much, much shorter. So let's start with mosaic aphe. What do I mean by mosaic aphe? I mean that we have an observation that's composed of internal nodules or internal compartments, or, although not shown here, a combination of internal nodules and internal compartments. Importantly, in mosaic aphe, the internal nodules and compartments have different imaging features, so different degrees of enhancement. Some may not enhance at all, some may enhance quite a bit. And notice that they seem to be distributed somewhat randomly. They are not distributed in any sort of meaningful fashion a priori. So the random distribution of internal nodules and or compartments, each of which have different imaging and enhancement features, is the definition of mosaicism. So here we have a 76-year-old man with cirrhosis, and we have a very large mass, maybe 10, 12 centimeters, something like that. And I'll outline the mass for you over here. And let me just tell you that this mass has areas of hypoenhancement and a nodule of hyperenhancement. And it also has all of these internal arteries. And this is an example of mosaic enhancement because the arteries, the compartments, and nodules seem to be randomly distributed throughout this mass. What is a differential diagnosis? Well, if the patient has no cirrhosis, then this is a hepatocellular cancer, such as an HCC or a fibrolamellar HCC. Or as a pitfall, it could be a conglomeration of multiple metastases altogether. If the patient has cirrhosis, then this is a hepatocellular cancer, either an HCC, it's an HCC. And as a pitfall, it could be a combined HCC cholangiocarcinoma. So this is our differential diagnosis for mosaic enhancement. Is there anyone in this room who would like to be told that they have a mosaic mass in their liver? Because if you have a mosaic mass, it's either a cancer, or a cancer, or a cancer, or a cancer. So the most important teaching point is that mosaicism is malignant. Now this particular patient has no cirrhosis, so let's get rid of those. And we're left with these as our possibilities. And then the question is, what can this be? Well, we see only one lesion, so it's unlikely to be a metastasis. And then the most likely one is HCC. And remember what I told you earlier, that although HCC is rare in the absence of cirrhosis, it's not rare in elderly men, especially elderly men with obesity or diabetes. So teaching point, elderly men can get HCC even in the absence of cirrhosis. But again, the more important point is this: a mosaic mass is malignant, and it's usually a primary tumor. Because, now you might ask, why do malignancies look mosaic on imaging? It's because they look mosaic on pathology. So here's an HCC, and here's an HCC. And notice that both HCCs have internal nodules, internal compartments. The internal nodules and internal compartments have different colors, sort of the analog to different imaging features. And notice that they seem to be randomly distributed. Like, why is this green one over here and this pink one over here? And why is this reddish one over here? And why is this yellowish one over there? So it's random distribution of nodules with different sizes and different colors, corresponding to the mosaicism that we see on CT and MRI. And because this pattern is so important, I just wanted to put together a collage, and you can let your eyes run through these different mosaic masses and start to create in your own mind a visual memory for the range, the spectrum of this particular pattern. Again, when you see mosaicism, it equals malignancy. Now, as a pitfall, sometimes we have a patient with metastatic disease in which multiple metastases will conglomerate together to look like a mosaic mass. So that's a pitfall. But notice that when you have a conglomerate metastasis, usually in the background, you have other metastases that are more characteristic in appearance. So it's not usually a fake out. Teaching point, mosaic mass is malignant if it's multiple and there's an extrahepatic primary, then it may be a conglomeration of metastases. Okay, let's go on to diagnostic set number 3, rim APHE. Rim APHE means that there's a continuous rim of enhancement along the outer aspect of the lesion. The rim might be thick, as shown here, or thin, and the rim may have a sharply defined inner border, or it may have an ill-defined inner border. All of these are rim APHE. And here is our prototypical example of 48-year-old man without cirrhosis. I draw your attention now to the arterial phase, and we see that there's a mass in the liver that has rim APHE with enhancement along the outside. So this is what we mean by rim APHE. And this particular mass has an area of non-enhancement centrally. And notice that this area of non-enhancement centrally does not enhance on the more delayed images. So this actual central area is necrotic. So that's why we have rim APHE in this particular case, because the viable tumor is on the outside, the necrotic tumor is on the inside, and the enhancement can't get in there. Okay, so what's the differential diagnosis for rim APHE? Again, we stratify, does the patient have cirrhosis or not? So if the patient doesn't have cirrhosis, then this is a metastasis or a cholangiocarcinoma or a combined HCC cholangiocarcinoma. If the patient has cirrhosis, then it's a cholangiocarcinoma, an HCC, a combined HCC cholangiocarcinoma, or a metastasis. So no cirrhosis versus cirrhosis. Notice that these two differentials are very, very similar. We've just rearranged things. So without cirrhosis, metastasis becomes number 1. With cirrhosis, cholangiocarcinoma becomes number 1, and metastasis becomes the least common. But notice that they have otherwise a very similar combination of things. And notice that HCC is not part of the differential diagnosis of no cirrhosis. And why is that? Well, first of all, rim enhancement is an unusual appearance for HCC, and HCC is an unusual cancer in patients without cirrhosis. So if I see rim enhancement in someone without cirrhosis, I don't consider HCC because it would be an unusual manifestation of a tumor that is rare in that particular patient context. Okay, now occasionally it's things other than one of these things. So it could be a sarcoma, but that's rare. Could be a lymphoma, but that's rare. If the patient has a fever and the enhancement is thin and non-solid-like, it could be an abscess or an inflammatory lesion. And if the patient has a history of previous ablation, then it could be an ablated lesion. But again, the rim of ablation zone is usually quite thin. Now, this patient has no history of fever, and this particular mass is thick and enhancing, so it's not an abscess. History is no history of ablation, so it's not an ablated lesion. So we're left with one of these entities. So is there anyone here that would like to be told they have a rim-enhancing lesion in their liver, because you get to choose among these as what you have in your liver? So rim-enhancing lesions are not good things to have. They are almost always malignant. So rim APHE, usually malignant. Now this particular patient has no cirrhosis, and sarcomas and lymphomas are quite rare, so let's ignore those for now. And which do we prefer? Well, this particular patient has multiple lesions, and so in this particular case, I would prefer metastatic disease. And also, if you look carefully, there's a corner shot, there's a primary pancreatic mass, here. This is the primary tumor, so this is metastatic disease from pancreatic neuroendocrine tumor. So this is a metastatic disease to the liver. Here's another example, 44-year-old woman without cirrhosis. She has a rim-enhancing lesion. She has no history of fever, so we don't like abscess. She has never had a previous ablation, so we don't like that. Sarcomas and lymphomas are rare, and we're left with metastatic disease, cholangiocarcinoma, and combined HCC cholangiocarcinomas. So in young and middle-aged women without cirrhosis, I get very worried about an underlying breast cancer, and I usually put metastatic disease as my #1 diagnostic consideration. And in this particular patient, that's what this was. This was a breast cancer metastasis. Teaching point in a young or middle-aged woman, rim aphe is very suspicious for metastatic disease. This conceivably could be a cholangiocarcinoma. This could be a combined HCC cholangiocarcinoma, but metastasis is probably the most likely in a young woman. Now this is just to show you some more metastases, rim-enhancing metastases with very chunky rim enhancement. And here's a breast metastasis with much thinner enhancement. And this is one of my favorite cases because this illustrates why large metastases are not diffusely hyperenhancing. So this patient has neuroendocrine metastasis, and you can see multiple different mets. Some are new and some have been around for a while longer. So this one just landed, okay? And notice that that tiny little metastasis is homogeneous. This one's been around a little longer, it's grown a little more, but it's still homogeneous. But this one has been around even longer, and notice that as it has grown, it is now developing central ischemia, and as the mets get larger and larger and larger, they develop more and more of a rim enhancement. So the teaching point is that while really small metastases can have diffuse enhancement, large metastases, especially once they get to be bigger than 3 centimeters, almost never are diffusely enhancing because they have this target-like appearance. So mets bigger than 3 centimeters, never say never, but never are homogeneous due to central ischemia. This is just to illustrate that cholangiocarcinomas can also have rim enhancement. And another teaching point here is that cholangiocarcinomas and combined HCC cholangiocarcinomas can develop in patients without risk factors. Now let's look at patients with cirrhosis. So this is a 58-year-old man with cirrhosis. So what's the differential diagnosis for rim-enhancing lesions in the setting of cirrhosis? So here's your differential diagnosis. Cholangiocarcinoma, HCC, combined HCC cholangiocarcinoma, and metastasis. So this is a cancer. There's really no other differential to give in terms of that. But which cancer is it? Is this cancer a cholangio, an HCC, a combined tumor? So remember, HCCs don't usually have rim enhancement, but HCC is the most common tumor in cirrhosis. Cholangiocarcinomas usually have rim enhancement, but they're less common. Same thing for combines. They usually have rim enhancement, but they're less common. So you can imagine that an uncommon manifestation of a common tumor or a common manifestation of an uncommon tumor may have about similar likelihood. So in the setting of cirrhosis, when I see rim aphe, I cannot tell the difference between these various kinds of tumors, and I give the differential. So the teaching point is that patients with cirrhosis are at high risk for developing HCC, cholangiocarcinoma, and combined HCC cholangiocarcinomas. HCC is the most common, but doesn't characteristically show aphe. Combined tumors and cholangiocarcinomas are less common, but typically do show rim aphe. So we can't tell the difference based on imaging, so we need to do a biopsy. This particular patient got a biopsy, and this was an HCC. How about this patient, 63-year-old man with cirrhosis? Notice that there's a rim-enhancing lesion in the liver. I know this is a cancer. What cancer is it? Is it a cholangio, an HCC, a combined tumor? I don't know. We have to do the biopsy. We get the biopsy. What was this one? This was a cholangiocarcinoma. How about this case over here? 61-year-old man, cirrhosis, rim-enhancing lesion. I know it's a cancer. What kind of cancer? I don't know. Got to do a biopsy. Biopsy, combined tumor. CT, 69-year-old man with cirrhosis, rim-enhancing lesion. I know it's a cancer. What kind of cancer? I don't know. Got to get a biopsy. This one's an HCC. Just when you think it's getting easy, though, 50-year-old man with cirrhosis, I know this is a cancer. What kind of cancer is it? Is this a cholangio, an HCC, or a combined tumor? Don't know. Got to do a biopsy. This one ended up being a sarcoma. So remember that the differential diagnosis does include sarcoma, although those are rare, and the only way to figure it out is to get a biopsy. Now, what if the patient has a fever? If the patient has a fever, then when I see a rim-enhancing lesion, I think this is probably an abscess, especially if I see a dilated bile duct, as I see right here, and I think this could be a so-called cholangitic abscess. So this patient was treated with antibiotics, and 3 weeks later, this lesion was gone. This was an abscess, not a cancer. What about this lesion over here? Well, this patient had a cancer that was treated with a radiofrequency ablation, and after radiofrequency ablation, having a thin rim of enhancement is very characteristic post-procedural finding. Notice that this rim of enhancement gets brighter and brighter and brighter, but it remains fairly smooth and uniform throughout. So this is the characteristic finding after ablation. And that's your differential diagnosis for rim enhancement. How about if you have rim enhancement and you combine it with peripheral washout? Well, what do I mean by peripheral washout? What I mean by peripheral washout is that you start out with rim enhancement, but over time, notice that the rim washes out, and as the rim washes out, notice that the center washes in. So you have gradual accumulation of contrast, or of most movement of contrast from the outside towards the inside, and that's known as peripheral washout. So as the periphery washes out, the center fills in, and this gradual fill-in is because the center of the tumor is either ischemic or fibrotic or both, so it acts like a sponge that gradually accumulates the contrast, and once the contrast gets in, it stays there. 59-year-old man cirrhosis, here's our prototypical case, and we have images at arterial phase all the way through 15 minutes. Let's magnify the arterial phase under 15 minutes. Notice that there's some peripheral enhancement initially, and notice on the delayed images, the enhancement has accumulated centrally. So what could this particular thing be? Well, remember, for rim enhancement, this was the differential diagnosis for rim enhancement. MET, cholangio combined. If there's cirrhosis, cholangio, HCC combined MET, or it could be a sarcoma, lymphoma, abscess, or ablated lesion. So the differential diagnosis for rim APHE with peripheral washout is exactly the same, except that this peripheral washout excludes 2 lesions from consideration, and now we are left only with cancers. So peripheral washout is malignant, period. There's no benign process that I know of that can cause this imaging appearance. What about this particular case? Well, this particular man has no cirrhosis, and if we look carefully, we see that this patient's mass is obstructing the bile ducts. So the single most likely cause of a mass that's malignant obstructing the bile ducts is going to be a cholangiocarcinoma, which is what this was in this particular case. This is just another example of peripheral rim enhancement, rim APHE with peripheral washout, just to give you another look at what that looks like. This is the peripheral washout appearance. Just to show you a cholangiocarcinoma that has rim APHE initially, notice the peripheral washout with the central enhancement. And here is a patient with neuroendocrine mets. Notice the rim enhancement in the arterial phase. Notice the contrast gradually getting into the spongy middle with peripheral washout. Now, some of you might be wondering, especially if you haven't done that much MRI and you've done mainly CT, you might be saying, I don't know what you're talking about with this central pooling and the peripheral washout. I don't see it that much on CT. And the answer is you probably do. You just don't window your images harshly enough. So here's a breast met on CT, and I think you can appreciate that there is rim APHE. And if you look very carefully on the delayed phase, there is central enhancement with peripheral washout. You just have to image your window levels, your image narrowly enough to see it. Now, how can this help you? This can help you because it can help you avoid mistakes. So this is a lesion that was diagnosed by a board-certified abdominal fellowship-trained radiologist as a hemangioma. And I think the reason this was called a hemangioma is that it has peripheral enhancement in the arterial phase. And notice that it holds onto contrast, and it sort of looks like it's following the blood pool. See, if you compare the enhancement here to the enhancement in the heart and the enhancement in the aorta, it looks very bright. So remember we said earlier that hemangiomas follow the blood pool. This sort of looks like a hemangioma. But why is this not a hemangioma? The reason it's not a hemangioma is let's look again at that arterial phase rim enhancement. And now let's take that rim enhancement and move it to the delayed image. And when we move it to the delayed image, we can see that the area that had arterial phase rim enhancement is not holding on to contrast. So the area that was rim enhancing has faded or washed out. So this is not a hemangioma. This is a metastasis with arterial phase rim enhancement and delayed central enhancement with peripheral washout that was misdiagnosed as a hemangioma. So whenever I see a lesion like this, I mentally look at the area of rim enhancement and superimpose it on the delayed image. And if the area of rim enhancement corresponds to the area of sustained enhancement, then I'll call it a hemangioma. But if the rim enhancement is bigger than the area of sustained enhancement, then I'll call it a metastasis. And here's a similar example. This patient has HCC, and we see that this lesion has arterial phase rim enhancement. We transpose the rim enhancement onto the delayed image, and we can see that the area of rim enhancement is not corresponding to the area of delayed central enhancement. So this is actually an area of peripheral washout, and this is a cancer. Now, is this an HCC? I don't know. This could be an HCC or a cholangio or a combined tumor. Okay, last diagnostic set, peripheral discontinuous APHE. So peripheral discontinuous APHE, we have globules or nodules of enhancement. These globules or nodules are peripheral, and these globules or nodules are discontinuous. So they are not touching each other, discontinuous peripheral APHE. And here's our prototypical case, a 38-year-old woman, abdominal pain, no cirrhosis. We see a large mass. Notice that we have globules of enhancement. Notice that these globules of enhancement are discontinuous. They are not touching. Notice that over time, the globules get bigger and expand. And as they expand, they're following the blood pool. Notice that the area that initially was enhancing holds on to contrast. So these globules progressively expand. They don't move, rather they just simply expand. Over time, they continue to expand and expand and expand. And if we wait long enough, and it wasn't really necessary, but in this case we did, then the entire mass will fill in, matching the blood pool at every phase, except if mass is really large, there may be a large area of central liquefaction. Now, this large area of central liquefaction is sometimes called a central scar, but notice that this central scar looks nothing like the central scar of an FNH, which was delicate and stellate. This looks like a large cavity. And if we look at a T2 weighted image, this particular cavity is very liquidy bright. So it's not just a little bright, it's liquidy bright because it's not a scar at all. It's literally an area of cystic degeneration in the middle of this particular lesion. Okay, so what is this particular lesion? What is the differential diagnosis for this particular pattern? Well, if the patient has no cirrhosis, the differential diagnosis is hemangioma. Slow fill venous malformation. And if the patient has cirrhosis, the differential diagnosis is hemangioma, more correctly known as a slow fill venous malformation. So notice now, there's no differential diagnosis. Doesn't matter whether you have cirrhosis or you don't have cirrhosis, whether you want to call it a hemangioma or a slow fill venous malformation, benign, 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 benign. So then the question is, okay, so this patient has no cirrhosis, so this was a slow fill venous malformation, but it's benign. So why am I showing you this? Well, this is so easy. There's no differential diagnosis. And the reason I'm showing it to you is it's not always, first, let me show you this. You've already seen this case before, but here is a CT, and we see a lesion and we sort of hallucinate that there's a puddle of enhancement, and maybe a puddle, and maybe a puddle, and maybe these puddles are expanding and coalescing, and we wonder if this is a hemangioma, but we're not positive. So what can we do to prove conclusively that this is a hemangioma slash slow fill venous malformation? What we do is we bring the patient back for an MRI, and when we get the MRI, we can see that the puddles are there. We can see that these puddles coalesce and expand and follow the blood pool, and this is a hemangioma. But the reason I wanted to spend a little bit of time on this is that radiologists don't always have such an easy time with these hemangiomas because there's a pitfall. And the pitfall is that you can have a necrotic tumor with peripheral nodules. So let me show you this case here. Is this a hemangioma? Is this a slow fill venous malformation? Here we have a nodule, a nodule, a nodule, a nodule, and they sort of look discontinuous. And maybe there's sort of a little bit of a rim of enhancement here, so maybe you notice that rim and you're worried about it, but you sort of think that this looks like a hemangioma, and you want to call it a hemangioma on this arterial phase. But let's look at the portal venous phase and the 3-minute phase. Do these puddles of enhancement expand? No, they don't. They stay exactly the same size. Do these puddles follow the blood pool? No, they don't. They wash out to become darker than liver. Notice that the blood pool is brighter than liver, yet this is darker than liver, so they are washing out. So these puddles are not expanding. These puddles are not following the blood pool. They are washing out. This is not a hemangioma. This particular patient had cirrhosis, and so now you know in cirrhosis, a nodule that contains multiple inner nodules, that's a mosaic appearance, so this is a cancer, and the most common cancer in cirrhosis is HCC, so this is an HCC. But before I get to that, I just want to point out that these nodules wash out, they do not expand, so this is not a hemangioma, this was an HCC. So one teaching point is do not make the diagnosis of hemangioma on one phase only. You really want to have 2 phases to be able to see that expansion and the following of the blood pool. And the other teaching point is that if the nodules wash out and do not expand, it's not a hemangioma. So do not make the diagnosis of hemangioma if the puddles wash out or fail to expand. So here's a case that was read by a board-certified fellowship-trained radiologist as a hemangioma, no differential diagnosis, so that this patient was diagnosed with hemangioma. But if you look at this case, and it sort of looks like a hemangioma in the arterial phase, doesn't it? We see sort of these puddles of enhancement. They kind of look peripheral. They're sort of matching the aorta and enhancements. This kind of looks like a hemangioma. But on the portal venous phase, are these puddles following the blood pool, or are these puddles washing out to become darker than liver? They are washing out to become darker than liver. So these are not hemangioma puddles. These are the viable portions of a partially necrotic cancer. This was a metastasis to the liver, not a hemangioma. So, teaching point. Large necrotic cancers may have peripheral nodularity and be mistaken for hemangiomas. And I see this maybe 10 times a year. If the nodules wash out, it's a cancer, it's not a hemangioma. Okay, so let's summarize. We talked about 5 diagnostic sets based on arterial phase hyperenhancement, or APHE. The 5 diagnostic sets were diffuse APHE, mosaic APHE, rim APHE, peripheral discontinuous APHE, and rim APHE with peripheral washout. A key question, cirrhosis, 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 because the presence of cirrhosis changes the differential diagnosis. And because of that, for every diagnostic set, we always have to ask ourselves, does the patient have cirrhosis or not? Diffuse APHE, prototypical case, if the patient does not have cirrhosis, it's hepatocellular. FNH is most likely, followed by hepatocellular adenoma. If the patient has Budd-Chiari, it could be a hypervascular regenerative nodule. It's possible in a few years we will reclassify hypervascular regenerative nodules as adenomas, but we haven't done that yet. Fibrolamellar HCCs tend to be heterogeneous, and the heterogeneity is not explained by a central scar. Conventional HCCs, quite rare in the absence of cirrhosis, except in other countries if they have hepatitis B, or in the United States, elderly men, especially with obesity, diabetes, or alcohol intake. Cirrhosis, we can also think of non-hepatocellular lesions if they're small. So rapidly enhancing hemangiomas less than 15 millimeters, metastases less than 3 centimeters. In cirrhosis, we're also thinking hepatocellular. We're thinking conventional HCC or dysplastic nodule. And regardless of cirrhosis, it could be a pseudo lesion such as a perfusion alteration, which is also known as a transient hepatic enhancement difference. In the setting, mosaic enhancement is defined by the presence of multiple inner nodules or compartments in random distributions. In the absence of cirrhosis, we think hepatocellular cancer, HCC, or fibrolamellar. In the setting of cirrhosis, we think HCC, but there's pitfalls. In the non-cirrhotic liver, it could be a conglomeration of metastasis. In the cirrhotic liver, it could be a combined HCC cholangiocarcinoma, but not so important to memorize this. The important thing to memorize is cancer, 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 mosaic masses, very bad. They look pretty, but they're very bad. Rim-enhancing lesions are almost as bad. Cancer, 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 cancer. Two exceptions, abscesses or inflammatory lesions or ablated lesions. Rim APHE with peripheral washout eliminates the non-cancers, and we're just left with a potpourri of different cancers, and the only difference is sort of where they get ranked. And the ranking makes sense, right? Because in someone without cirrhosis, we think of the most common lesion, which is metastatic disease. In someone with cirrhosis, we're not sure, because with cirrhosis, it could be an atypical manifestation of a common cancer or a typical manifestation of an uncommon cancer, and they're equally likely. And finally, peripheral discontinuous APHE is a hemangioma, period, but just be aware that in order to call this, what you really want to see is that the puddles expand and follow the blood pool. If the puddles do not expand and or do not follow the blood pool, it's not a hemangioma. Think necrotic tumor with peripheral nodules. Okay, thank you very, very much.